Today I'll be talking about maternal and infant health in India. This presentation was put together by Dr. Shroff and myself. So an overview of today's presentation, it will have an introduction to myself. We'll be discussing global maternal health issues, global infant health issues, and we'll also be touching upon the Odisha Maternal Infant Health Project. So an introduction to myself, I'm a physician that has many passions such as knowledge and teaching, and I'm also interested in family medicine and global health. Presently, I'm working as a research assistant at UBC alongside Dr. Shroff. So a little bit about my background. I'm Canadian. My parents and grandparents are from India, which makes me a diasporic Indian. My family roots are in farming and agriculture, as grandparents were large landowners in Punjab. My mother was the first woman out of her village to complete a bachelor's degree. So I visited India multiple times in the past, and throughout these visits, I've developed a passion for improving healthcare in India, and I've also participated in health camps in rural villages for performing eye exams for the needy. So some background into Punjab. It means the land of five rivers. It is one of the most fertile regions on earth. It's a northwestern state, as you can see on the map here, and the capital city is Chandigarh. The population is approximately 28 million, which is majority Sikh, and it also has the lowest poverty rate in India. Agriculture is one of the largest industries of the state, and it is India's largest supplier of wheat and rice. So this translates into approximately 3% of the world's production of these crops, and approximately 2% of the world's cotton comes from Punjab. So now we'll be discussing maternal and infant health in India. So India has the highest maternal mortality rate in the world. Nigeria has the second highest rate. The maternal mortality rate has reduced, but it's still very high, and this varies according to the region. So they needed to reduce the rate by three quarters, and they did so less than half. So therefore, they did not meet the MDG for 2015. So looking at some statistics from maternal mortality from 1990 to 2013, as you can see in 1990, the MMR was 560 per 100,000 live births, and in 2013, that number reduced to 190 per 100,000 live births. So as you can see, the MMR has significantly decreased, but we still have a long ways to go. So some social determinants of maternal health in India. There are a lot of social hierarchies and a lot of poverty. Underage girl marriages are very common. The legal marriage age in India is 18 for females and 21 for males. However, still 1.4 million marriages in 2001 were between the ages of 10 and 14. There is a low literacy and a low health literacy rate. And some complications of maternal health include HIV, dengue fever, malaria, etc. And there were 320 HIV-related indirect maternal deaths in India in 2013. And so a little bit more information about the deliveries. So about approximately 67% of deliveries occur at home, 51% of maternal deaths occur at home, 34% of deliveries occur at a proper facility, and 38% of maternal deaths occur at the facility. Some more health concerns for maternal health in India. A major concern is anemia. Anemia is a major source of birth complications. Quality perinatal care with counseling is uncommon in India. 65% of women had 2 years or more between the births, and 53% of women who died had faced complications during delivery or childbirth. And some other concerns include delay in decision making and identification of appropriate health facility and accessing these services on time. So anemia, as we said, is a widespread problem in Indian women, and while pregnant, it can become a serious health concern, leading to complications such as decreased energy, preterm delivery, heart problems, and low birth weight, etc. And the rate amongst Indian women is increasing annually. For example, approximately 30% of maternal deaths in India are due to anemia. It's said that 1 in every 2 Indian women, about 56%, suffers from some form of anemia. And routine screening and iron supplementation before and after pregnancy is crucial in preventing these complications and these deaths. So, some tips to improve maternal health in India: a greater equality for women is needed in society. There needs to be economic changes and help in reducing poverty. There needs to be more female education, which leads to jobs and generates incomes. And more female landowners need to be in place, as this leads to empowerment. Also, promoting female health literacy is an excellent path to community health. There needs to be regular vitamin and iron supplementation. The use of skilled birth attendants and transportation and access to hospitals and other healthcare facilities is very important for improving maternal health. So now we'll be looking at infant health concerns in India. These are directly linked to maternal health. The infant mortality rate was 41 per 1,000 live births for the year 2013, and India is unlikely to meet IDG of less than 39 for 2015. Approximately more than 2,000 newborns die each day in India. This translates to approximately 8,000 deaths per year. And some causes of infant mortality are prematurity, low birth weight, sepsis, infections, birth asphyxia, pneumonia, tetanus, and congenital abnormalities. So, some things that can be done to address these infant health concerns is there needs to be expanded neonatal and intrapartum care. There needs to be better case management of diarrhea and pneumonia. And also, the addition of new vaccines to immunization programs could substantially reduce child deaths in India. Another large topic is the violence against women in India. This is a very important topic as this is increasing yearly. The most common type of violence against women in India is rape. Every 29 minutes, one rape is occurring in India. Other types of violence against women in India is domestic violence, acid throwing, dowry deaths, and honor killings. And these are underreported due to taboos and misogyny. And these can be linked to mental and physical health problems. And this, therefore, leads to increased female deaths due to infanticide, suicides, and murders of females. So, effective approaches to stopping the female violence: there needs to be educational interventions to change social norms and to break the code of silence that's in place. There needs to be early identification of abuse by health professionals, and women shelters and programs need to be in place to empower the women, and there needs to be safety and supportive resources for victims of abuse. There also needs to be improved laws and access to the criminal justice system for females. Now we will be talking about the Canada India Maternal Health Project. This is a brand new project. It was started March 31st, 2015 at the International World Public Health Conference where Dr. Shroff and Dr. Som met and talked about it. And from there, it gathered a tremendous amount of momentum, and we have been underway since. So, a little background about Odisha. The population is approximately 41 million. Oriya is the official language. They also speak Bengali, Hindi, Urdu, Telugu, and Santali. The literacy rate is 82% of males and 64% of females are literate. Approximately 40% of the population falls under scheduled castes and tribes. Some of these tribes include Santo, Banda, Munda, Kanda, Mahali, and Kora. In Odisha, almost half of the population lives below the poverty line. And the maternal health in Odisha, there are approximately 7 maternal deaths per day. The MMR is 358 per 100,000 live births. This is due to the poverty and the poor social status, the lack of skilled healthcare personnel, and the poor infrastructure in Odisha. So, in our project, we will be focusing on some clusters. These include: number one, training of midwives and other healthcare professionals, linkages with traditional healthcare providers, like for example, Ayurveda, Siddha, and Unani. We will be focusing on community development, research and evaluation, grant writing and fundraising, and also knowledge transfer and filmmaking for the Odisha project. And I would just like to end with a quote from Nelson Mandela, who said that health cannot be a question of income, it is a fundamental human right. So thank you for listening.
Thanks, Rajak. So just prior to your Raj's presentation, we had a presentation from the Hopeproof Pakistan. They were describing rural communities, mainly farming, but similarly isolated, neglected, and not having had much opportunity for advocacy. And their goal is to try to educate and empower the community health workers that are accessible there, like the lady
the lady health workers, yes,
workers, and the community midwives, and also the drivers. You know, the drivers who are going to have to pick up obstetric emergency and move the woman to a place where she can receive care. But the unusual thing about your project is also the desire to engage and with alternative or allopathic healthcare providers who are already respected in the community.
Yes, I think that's definitely one of the innovations, Peter. It's really unusual in the world of global health to even be talking about systems of holistic and traditional medicine, despite the fact that in a country like India, at least 75% of the population uses Ayurvedic, Siddha, and Unani as their primary form of healthcare. It is the majority of the care that people are receiving. It's true all over Asia that traditional and holistic healthcare accounts for the majority of primary care. In the African continent, about 80% of the people use traditional and holistic medicine. Latin America, it's very similar, and the Middle East, it's very similar. So it's really unusual and strikingly so that we talk about these systems of medicine in holistic health, because even our holistic health, our global health programs are come from this allopathic or Western biomedical framework. And the work that I've been doing over the past many decades to look at health for all talks very much, my work talks very much about the need to bring a holistic multi-paradigmatic framework together, so that we work with it with what actually has some evidence for improving people's health, and we don't ignore potential sources of good healthcare. And that's exactly what we're trying to do in this maternal health project. Rarely in the literature on maternal mortality is there any discussion of working with traditional medicine at all. So I think you're right. This is definitely very innovative. And I actually did my PhD at U of T, and my PhD thesis was on Ayurvedic medicine. So I have a personal interest in this system of medicine, and I've been studying it for many years. And as I told you, one of the scholars who's coming from China to work with me also has a particular interest in it. Some of the other people who I've recruited to the project are themselves holistic providers here. So we have Dr. Brenda Liang, who's a naturopath PhD, and Dr. Emily Solomons, who's a traditional medical doctor who works entirely in the area of fertility and women's health. So we have Canadian healthcare providers who are interested in this, and we're just setting up our 3-month, 6-month, 9-month, and 12-month goals for how we're going to connect with the Ayurvedic, Siddha, and Unani practitioners in the regions in Odisha where we're going to work. And we feel like this is going to make a really big difference, because in the places where people die, there actually are people available. And we want to know, what kind of training? Do they have any emergency obstetric training at all? What kind of resources already exist in these rural and remote areas where we're going to be working? And we don't know yet. We don't know the answer to that question. So we're still at our really early inquiry stage. We know that prior to colonization in India, Ayurveda was a full and extant system of medicine. that's 500 years ago now. So we're just at the point of looking at what kind of prenatal Ayurvedic knowledge does exist, and what is the standard of care right now that's practiced in this area that we're practicing in. But of course, the most important thing is to use an evidence-based approach for what's going to create the healthiest babies and the healthiest mothers. So in the case of hemorrhaging, which is usually the number one cause of death for women during childbirth, the number one complication is hemorrhaging. And as Dr. Randhawa told you, that's complicated and partially caused by anemia. What we know works very effectively for treating hemorrhaging is misoprostol, followed by a trip to a hospital. And if that, that's pretty much the standard of care. So we would envision doing what many other health projects have done around the world, which is equipping traditional birth attendants or midwives, or perhaps Ayurvedic physicians, with misoprostol and helping them to figure out a way to get their patients directly to a hospital.
Right. Yeah.
So, Raj, I have a question. You mentioned Odisha's population, all those stats, but you didn't mention what is the source of income, because it's very strange that their literacy rate is pretty high, 80% in male and 54% of female. Previously, Dr. Maria had talk about issues related to the negativity of this mental health in the woman is because of lack of education. So her cycle started with the lack of education, and it goes to puberty, economic, and so on. But then when we look for the Odisha's stats, it shows they had a good literacy background. So it's still having the similar outcome. I would like to know what is the other reason behind, if it's not lack of education or it's not.
So literacy rates sometimes, first of all, are not accurate. Official literacy rates are often different than the rates which actually exist. So we're not entirely sure if the rates are that high. Oftentimes, we don't even have proper demographic statistics for many places, and India is a really solid case in point for that problem. I can tell you, I'm South Asian myself. Both of my parents were born in India. We don't know the exact year of my mother's birth, so everything from birth registries to other registries are very poorly collected. So I'm not 100% sure if that's the correct literacy rate. But even if it was the correct literacy rate, there are other things that really complicate the maternal health indicators. And we alluded to them earlier. In India, there is a very strong social hierarchy. And the people who we are going to be working with are the people who are very close to the bottom of that hierarchy. And so, as you know, there's a caste system within Hinduism, and at the bottom of that hierarchy are a group of people called the Dalits. Mahatma Gandhi called that group of people the Harijans, meaning children of God. But because of that very strong social hierarchy, which is strongly linked to economics, people on the bottom of the hierarchy, even if they're literate, have a hard time finding work. So their social and economic conditions lead them to a state of poverty and social marginalization, which then affects their maternal mortality rate. So if I could just quickly add, the Dalit population all over India in the past few decades has actually raised their literacy rate as well as their overall education status by quite a significant amount. It hasn't translated yet to improving their economic conditions.
Class, how is the tribal groups, how are they ranked between it? Are they ignored? Are they lower than Dalits? Or are they just others and have no meaning to the class system or the hierarchy?
They're very close to the Dalits in many ways, but and some members of the indigenous community are actually Hindus. Others aren't. They belong to other religions, or they're more animist, or believe in different things. But they would be lumped together at the bottom of the social hierarchy, and it's really hard to start separating apart who has it worse, because it's just darn hard for both of those groups. So I never want to compare too much, but it's a situation that's very similar to the rest of the world for the indigenous populations. They had stewardship of the land that is now taken over by other people, and so they live in the rural areas, which often aren't as fertile, and so they have great challenges with actually growing food, and all of those kinds of challenges exist.
Like the Aboriginal peoples in Canada, the responsibility for their well-being rests in the with federal government. India is also a federal state. Do tribal groups is their well-being the responsibility of the federal government or the provincial government or the state government?
It's a combination. Yeah, but unfortunately, just like Canada, when there are multiple bureaucracies involved, it's very easy to fall between the gaps.
Well, the question was about filmmaking, and what was your vision for filmmaking as a knowledge translation medium?
Oh, well, India is the land of Bollywood and film, and there is a tremendous opportunity in India to change culture and to spread knowledge using that medium. So we've already been in touch with some Indian filmmakers to start making film about the group of women and children, the families who we'll be working with in the area of Odisha where we'll be working. Because surprising in this globalized world, that part of India, and particularly the indigenous peoples and people who are more marginalized, haven't had a lot of exposure. So we're really excited about using this really creative medium, not to paint a picture of sadness and devastation, but to show the everyday realities of people's lives, and to show that in every day there's some laughter and some joy, just as much as there is some pain and poverty.
Okay, well, thanks. If there's no other questions, thanks, Farah. That was great, and great that you could join us. And thanks, Rajak. I guess this is a work in progress. So that's the beauty of research, is it really continuously reinvents itself. It's both a research project, but it'll also be an advocacy project.
It's a health project. It's primarily a health project.
There'll be health and research, but health first.
Yes, absolutely. Well, thank you so much, Peter, and thank you to all of you. I've still got your names written down, so I won't read them all out. But yeah, thanks a lot, everybody.
Thank you.
Bye.
Okay.
Thank you.